So, welcome all for the ASAMI's webinar on current and laser of ASAMICON 2022. Now I request our secretary, Dr. Ravi Chauhan, to start the webinar.
Thank you, Dr. Shamsul. Good evening, everyone. So today we are having knee deformity correction, evaluation and management. Our speaker for today is Dr. P. N. Vasudevan. He is the head of Thangam Institute Orthopaedics, Kerala. And it's our privilege to have you, sir. And today also we are having Dr. R. Agarwal, Dr. Mangal sir, Harshat sir on our platform. So coming Dr. Vasudevan, he did his MS Ortho, D-Ortho, DNB Ortho, then he's also a member of National Academy of Medical Sciences. He's a senior orthopedic surgeon consultant at the Thangam Institute of Orthopaedic Surgery. Sir is also a trauma and Elizarov surgeon at Thangam Hospital, Palakkad, Kerala. He is well known for Palakkad Deformity Correction course. He was the past president of Kerala Orthopaedic Association, president-elect of OSIS, executive committee member of ASAMI India, former executive member of IOA. He has organized IOCON Kochi, OASICON Palakkad, COACON twice. He is a director of yearly Palakkad Deformity Correction course, doing Elizarov surgeries since 1991. He is a faculty of various national and international Elizarov courses and conferences. He had many guest lectures, orations, papers, medals, published many articles, including in JBJS. Welcome, sir. And today we are also having privilege that we may have Dr. Novikov, professor of Elizarov in Kurgan, for a case presentation on varus deformity around the knee in a short while. And it's my privilege to announce on behalf of our president, Dr. Ruta Kulkarni, she is not present today, that this year after a long gap, this date is wrong. It's on 17, 18, 19 June 2022. We are having our ASAMICON 2022. And after a long gap, we are having a physical meeting. It is to be held at Pune, Hotel Sheraton Grand. So I invite you all for our annual conference. Now I'm handing over to Dr. Shamsul to moderate the session. Shamsul, please go ahead.
Thank you, Dr. Ravi. It's a real privilege that we are having our eminent faculty, Dr. Vasudevan sir, for a very interesting talk. So without wasting time, I'll request Dr. Vasudevan sir to share his presentation.
Is it visible, Shamsul?
Yeah, sir, please go ahead.
Yes, sir. Yes, sir.
Good evening, all. So, Shamsul last week has been insisting me to give a talk today with a short notice. And the topic he asked me to give the deformity correction around the knee joint and its management. See, nowadays, recently one of my professor left us. So I thought it's always better because there can be a combinations of all these deformities. So this is what I mean by an angulation is a rotation. So here you can see a procurvatum deformity, which is actually a sagittal plane deformity around a horizontal axis. It rotates like this. This is an angulation around a horizontal plane. When you take an AP view, you can see here a cora around which there is a varus deformity. This varus, it is produced an angulation around this anteroposterior axis. So that's again a rotation around that axis. And when you call rotation conventionally, that means if an axis is in the intramedullary area, like when you put an intramedullary rod, it rotates around that, maybe externally or internally. So that is known as, again, rotations. In fact, it's an angulation around a vertical axis. When you describe all this as angulations, what is the one advantage? You can combine this angulation with that angulation. That is, a procurvatum sagittal plane angulation and a frontal plane angulations and resolve these two things into an oblique plane. Same way, you can combine this angulation and the rotation angulation and resolve into a new plane. So there are so many possibilities when you talk this way. So otherwise, you will always think rotation is something entirely different. So actually, everything is same. Here again, there is one more point. You can see here the cora is above the obvious deformity. Here the cora is at the deformity. So that means there is a hidden translation deformity along with that. So that is, these are all, when you see the X-ray, you must evaluate all these things. And for the beginner, we must know what is the mechanical axis of the lower limb. It's a line from the center of the femoral head to the center of the ankle plafond. The straight line connecting from the center of the femoral head to the center of the ankle joint. Normally, it passes through the center of the knee joint. So that means it's collinear. So all joint centers are covered by the long single axis. So that means joints are collinear to that. When it is shifted a little bit medial or lateral, it is known as mechanical axis deviation. It can be medial mechanical axis deviation or lateral mechanical axis deviation. What is mechanical axis deviation? It's a perpendicular distance from the deviated mechanical axis to the center of the knee joint. Normal values are 0 to 16 degrees medial. Not in the picture, short images, but in the real-time life, real-time bones or real-time X-ray. The alignment, when we talk about alignment, it's an important consideration not only for deformity correction, but it is very, very significant consideration for arthroplasties, fracture management, and all these things. So the most important part is when you try to correct a deformity, do not create a new deformity while treating it. So this is do no harm. So never create a new deformity. Look at this young man. He has perfectly aligned leg. But he was always complaining some instability in the knee joint. He already underwent a deformity correction and ACL reconstruction. So, and you can see there is a foot drop spin at the back. See this X-ray, full length X-ray. His knee joint is mal-oriented to the mechanical axis. The mechanical axis is collinear. It is perfect. But the joint is mal-oriented. So what is really happened here is, he originally had a distal femur valgus deformity. And since he was having a generalized ligamentous laxity, his femur was sliding medially on this. It was mimicking like an ACL deficiency. So he went to an arthroscopy surgeon. Naturally, he did a ACL reconstruction. He removed whatever that ACL there. ACL reconstruction was completed in half an hour. He had some more time. Then he thought he will correct the deformity by a closing wedge osteotomy of the upper tibia and put a staple there. And now his problem has increased. After this, since it is an acute correction, he lost his peroneal nerve and he developed a foot drop. And whenever he stands on this limb, you can see the tibia is slopey and the femoral condyle being spherical, it slides to medial side. So he was always having an unstable feeling in the knee joint. Here you can see it is horizontal. Here it is little oblique. So this was his X-ray. You can see his osteotomy, closing wedge osteotomy and the staples. And that is the knee joint malorientations. So now we have no other way other than correcting the primary deformity of the distal femur and the iatrogenic deformity of the proximal tibia. At the same time, I thought I'll just do a permanent nerve release, but the significance of it is not all because after 1.5 years. But anyway, I did that. I found the nerve was completely lost. And I did the correction. So this is one point where a femur deformity has been corrected by the tibia, which we should never do it. And this is a patient, you can see the perfectly aligned left lower limb. He had a tibial valgus deformity, which was corrected on the femur. A tibial valgus was corrected on the femur. See, ultimately his deformity was perfectly corrected, but knee joint is completely gone. In about 7 years, he developed severe pain in the knee joint, and the knee joint was completely damaged. So that means there was a custom, or there was a rule during our PG times. Whenever there is a valgus deformity, you correct on the femur. Whenever there is a varus deformity, you correct on the tibia. As a general rule, it may be right. Most of the varus deformities are due to tibia, and most of the valgus are due to femur in most of the cases. But still, we have to find out all cases are not, all valgus are not in the femur, all varus are not in the tibia. Here, unfortunately, a valgus deformity was corrected in the femur, but it was on the tibia. The tibial valgus was corrected in the femur. So this is again an error. This happened because of the old teaching, like you correct all valgus in the femur. Now look at this man who had a fracture during his childhood. He had a femur shaft fracture and developed a varus deformity. And as per the rule, old rule, he underwent an upper tibial osteotomy. For virus, genovirus, he did a upper tibial osteotomy. In fact, that was a femur valgus. Being it happened in childhood, it got decompensated at distal femur and proximal femur. And though it looks bad, but mechanical axis planning, the both angles were correct. And now what happened? His tibial valgus, which was iatrogenic, corrected by surgeons, remained same way. And by the time his femur was automatically molding it out. And femur corrected on its own, but the tibial deformity was not being corrected. Now the issue is he had a persistent genu-valgus and he developed a lateral compartment arthritis. And for lateral compartment arthritis, he was advised a total knee replacement at the age of 52 years. He came to me for second opinion. I did the correction. And now you can see the joint is opened out and completely aligned. And the tibia is also aligned. You can see that is the correction. He can even squat on the floor now. After about nearly 10 years, he has no problem. So this is another very interesting example of a lady doctor who had a fracture neck of femur at the age of 15, underwent many surgeries. It didn't heal. Then finally healed after a McMurray osteotomy. You can see an osteotomy and medial displacement osteotomy. And the non-union has healed. But it has changed the shape of the proximal femur. And during the multiple surgeries, the epiphysis of the femoral head has damaged. So she was developing extreme shortening and a mechanical axis deviation. The fracture has healed, and at the age of 35 years, she developed pain on the lateral compartment of the knee. This was the X-ray at the 35 years. The knee joint was looking perfectly good. And nobody could find out the reason, so it has been left like that. He came to me at 53 years, and I found his lateral compartment is completely gone. And here full-length X-ray shows mechanical axis going far away, lateral deviation. So this happened because of the shortening. The other side was growing, extreme shortening, and that resulted in mechanical axis deviation, and the lateral compartment is damaged, and the proximal femur deformity. This valgus deformity in the proximal femur. So that completely damaged it, and I told her to get corrected both deformities, but unfortunately she had gone for a total knee replacement. I have no idea what happened afterwards. So it is very, very important to do malalignment test so that we know where exactly is the deformity. And we must be knowing the total normal alignment, normal orientation. So this is normally a paper is kept under the table always for the juniors to always cross-check and verify it. This is the mechanical axis, that is the hip joint orientation line, distal femur line, proximal tibial line, distal ankle line, and the angle. You just have to remember the medial MPTA is about 87 to 90 degrees, and mechanical LDFA about 87 to 90, and proximally LPFA is about 90 degrees, LDTA about 90 degrees. So everything is very near 90 degrees. So ultimately, the main aim is while walking, the joint should be parallel to the floor. So you know, in the hip joint, hip is a little bit outside the center line. So while walking, we try to bring the foot to the center. So that makes about 3 degrees of varus in the hip joint, adduction in the hip. That adduction will make the knee joint parallel to the floor. So ultimately, all joint surface should be parallel to the floor when they are walking. And always remember that we are only as good as our X-rays. A difference between the best and the worst, let it be understanding, let it be result, let it be whatever thing, is only, in orthopedics, it's only a good X-ray. If you have a bad X-ray, you will have bad understanding, you will get the worst outcome. If you have a good X-ray, you will get the good outcome. So look at this girl who had this deformity, which I used to show in most of the meetings. See this, the heel is looking forward, the foot is at the back, there's some sort of rotations around, and you can see a crease here. The foot is looking forward. So when I asked for an X-ray, this is the X-ray which I got. This is an AP view. You can see the neck looking like lateral, lesser trochanter, GT, and the fibula on the medial side. So technicians are trained to take X-rays of normal people in anatomical positions. When anatomy is distorted, we have to go to the X-ray room and help the technician so that he can take a better X-ray. So what I did was, I have to solve it. So I went to the X-ray room and positioned patient in such a way that de-rotated the limb, such a way that I could locate her patella and keep the patella facing the roof. And I found her knee joint movement, which was in this plane. So made the knee joint plane parallel to the floor and patella to the roof and kept the limb like that. And I found her foot was now looking at her shoulder. So that was her X-ray. I mean, her position. I took the X-ray. This was the X-ray. And that is the hip joint orientation line, anatomical axis, and the distal axis. So overall, it was found to be about 170 degrees. And which the mechanical axis was not meeting anywhere in the X-ray, it was meeting far lower down. Then I have drawn a middle line and found to be 65 degrees and 105 degrees at two levels. Overall, it's 170 degrees of distal femur valgus. Now the problem there is how to correct the deformity. Now with the Ilizaro, you can plan it out, you can find out, you can do one osteotomy there, you can do one osteotomy here. But the problem is you have no space to put a finger here. Can you pass a reference wire for the knee joint? You can't pass a reference wire here. You cannot pass a olive wire there. And is it possible to do an osteotomy of this and here through this? So I cannot even put my finger there. Or can I do a permanent nerve release? Nothing is possible on the lateral side. Now I have to do all my pins on the medial side. And I have to put all the incisions on the medial side to the osteotomy. So I have no other way. I have to go. I did my Doppler studies. I marked the vessel, femoral artery on the Doppler.
In the end, it's two things. Unless we do two things.
And the mark, as soon as you prepare it, the mark will go. Then I have to retain it. There is no markers available for keeping it long. And at that moment, my daughter told me, you can just put a henna on top of that mark. I just put a henna. I just bought 5 rupees that henna cone and marked the femoral artery. And the femoral artery was showing, but the APL laterally marked it. Now I can safely keep away from the femoral artery. I can do a pin on the medial side. I can do an osteotomy here. I can do an osteotomy here. I can put olive wire from medial side. All this is possible. So I made a frame like this. 1 inch, the next inch, all these are half rings, which I can add on later. I put a medial olive wire like this, a cut olive, and that is a hip joint AP. And you can see all pins on the half rings. I did a osteotomy here and another osteotomy there. And that is the complex distraction systems. It started coming out like this. And I got a full correction without peroneal nerve release. She never had a peroneal nerve weakness. And from there to here, it's only your understanding. Just go to the X-ray room, take a good X-ray, plan it, and anyone can make this. And that is it. At the end, the end result is perfect. Now, the frontal plane deformity is varus and valgus bowing deformity, both femur and tibia. So I'll touch on, this is only an introduction so far. So to discuss the single plane deformities, generally I take a banana. To teach the students, my fellows, I take a banana. So the banana doesn't have an anterior surface or posterior surface, medial and lateral. So whichever position I can keep it. So they are not fixed to the AP view and lateral view. So when I want to make a frontal plane, I keep the banana like this. That is the proximal axis, distal axis. And that is the chora and bisector line. And you can do a osteotomy at the bisector line and open it out. So that is called frontal plane varus deformity. So you can see this man, I think about 45 years, he was referred to me for HTO by an arthroscopist. So that was his maximum knee movement possible. He had an injury of the femur and tibia 25 years back. He was living like this and later he developed knee pain and went to an arthroscopist. He advised an HTO. So when I took an X-ray, I found he is having a distal femur varus and a proximal tibial varus and a quadriceps limb length disparity of about 3 centimeters and quadriceps adhesions. So all these problems are there. So can I correct all these things by an HTO? That won't be correct. So my only option is I have to correct it in the femur, correct in the tibia, and the tibia I can do an illusory and lengthen it up. And if I am doing a plating for the femur, I can do a quadriceps plasty in the femur and correct it simultaneously. So whenever I can get an acute correction safely, I prefer an LCP or interlocking nails over an illusory. So I don't need illusory for that. So that's what I decided for this patient. I did a quadriceps plasty. This was his original movement, and you can get, I got this much of range of movement. And I did an osteotomy there and fixed it with a LCP, distal femur locking plate. And the proximal tibia, I decided to do an illusory, proximal tibial osteotomy, lengthening of 3 centimeters, and the deformity correction. So wherever I can get an acute correction, like illusory. I cannot correct a limb length disparity in a one stage. I cannot correct those things, is not possible. So I have to do a lengthening. I need a slow correction of the deformity. So for that, I need illusory. So I prefer there over an implant. So you can do you can see this. I did the plating and the femoral deformity has been corrected. And that is the femoral plate. And this is a tibial deformity where I did the iliopsoas correction, lengthening after correcting the deformity. That is the final walking on the frame. So that you can see the frontal plane banana deformity and corrected. So whereas this is again a lady with the same deformity, but unfortunately, her X-ray shows a different picture. She has a diaphyseal femur deformity and joint line narrowing and a proximal tibial varus. So this is a different ball game. So do I need an iliopsoas for her? Yeah, I can do an iliopsoas for tibia and overcorrect the tibia and correct the deformity slowly. For the femur, I thought I'll just go by a interlocking nail. So this is what I did. I had an interlocking nail in the femur, corrected her deformities. The tibia, I did a iliopsoas and corrected her deformity slowly. And that is the correction which I got. So this girl again came to me for iliopsoas. So this was her X-ray. You can see the malorientation of the knee joint. And that is the magnitude of the deformity. That is in the supracondylar femur. So I don't need, with the present latest LCPs or even locking nails, I don't need an iliopsoas here because this much of an acute correction is not a problem. So I plan to correct it acutely and did it like this. You can see the osteotomy and did a plating. And that is before and after. Whereas this young boy had this deformity with a severe genovalgum, I cannot do an acute correction in this case. So I planned it. These are real deformity. I cannot take a full-length X-ray of him. I did a multiple cut films, marked it like this. That is his mechanical axis going far away. He had femoral deformity and tibial deformity. So I had to correct both femur and tibia. And this is after stage 1. So this is after stage 2 on the ring fixators. One femur. Initially I did on the right femur and left tibia. Then later I did on the left femur and right tibia. And that is at the end of the correction. And before and after. This lady, again, a relative of my close friend, she was in Scotland. She had a knee pain and they advised her to wait some more time so that they can do a total knee replacement. So you can see the mechanical axis is shifting on the medial side. And the right side is good. Left side was a little out. Her femur deformed, there was no deformity in the femur. Then I started doing a planning on that. These are Murphy's lines. And this is the yellow line and the green line. This junction is the magnitude deformity for an HDO. And I did the osteotomy at this level. And that is the frame. And that is how it is at the end of the correction. And after removal of the frame, we can see the mild 2 degrees of valgus. So this girl again had a bow leg deformity. See the X-ray? The mechanical axis going far medial. And that is the tibial femoral axis. So I resolved the buoyant deformity into one plane in the femur, one plane in the femur here. Whereas in the tibia, I do a 2-plane deformity correction, 2-level deformity correction. So this was the frame made for her on the right femur and the left tibia. Hinges is already placed. I do an osteotomy here. I do another osteotomy there and correction at 2 levels on the tibia and one osteotomy here and correction on single level. That was the frame on the limb after osteotomy. And this is the final X-ray. You can see it's completely corrected. Though the anatomical axis is not correct, the mechanical axis is good. Before and after. And I could achieve it without any loss of function. That is the range of knee movement. Now we go on to sagittal plane deformities, which include recurvatum and procurvatum deformities. So that is the sagittal plane mechanical axis. When you stand normally, the mechanical axis goes in front of the center of the knee joint. So with 10 degrees of flexion, or 5 to 10 degrees of flexion of the knee joint, still the mechanical axis is at the center of the knee joint. The center of the knee joint is the posterior wall of the femur in the lateral view, and the Blumenstadt's line joining that point is the center of the knee joint. Blumenstadt line and the posterior cortex line. When the knee is flexed 5 degrees, it still passes through the center of the knee joint. And that is why even with 5 degrees walk flexion, people can walk better. So this is again the same banana, but here this is anterior, this is posterior. So this is a procurvatum deformity. You can do the same osteotomy and correct it. There is no difference whether it's a frontal plane or sagittal plane. You keep the hinge in a different plane. You change your orientation, that's all. So ultimately it is same. So this is an example of stiff non-union of the femur. You can see a small sequestrum there and a sclerotic bone ends. But clinically, it was behaving like a stiff non-union. There was no abnormal movement demonstrable there. So I thought I'll just correct it like a banana. I put a fixator on that. I didn't do any debridement as there was no infection, no clinical signs of infection for last 6 months. I did just put a frame, did a slow correction on the hinges. The hinges you can see far away anteriorly. That's a distraction hinge. You can see the hinge is here. So it's a distraction hinge so that I'll get length along with correction. This is after full correction. I lock the frame system. This is after removal, the before and after. So now look at the sclerotic bone. What happened to sclerotic bone? And it has grown bone in between also. So even the medullary cavity is forming. So there is no other deformities. And the sclerotic, all white bones are not bad bones. The sclerotic bone is sclerosed only because of the mechanical stresses over there. So this girl had a tibial procurvatum deformity. You can, that's the proximal joint line and proximal mechanical axis, distal mechanical axis. A long-standing post-infectious problem. So when you correct this, I always, in such deformity, when you do it here, I would like to do a peroneal nerve release. So I don't want to take a risk in a young girl like this. So I did a peroneal, that is the peroneal nerve. I did a peroneal nerve release and put a frame like this, and fibular osteotomy and a tibial osteotomy at that level. And you can see the slow correction by osteotomy rule 2. The hinge was lying little far away, but I did the osteotomy a little bit distally. And it has produced a translatory correction, but you can see the mechanical axis is perfect. So that is the advantage of osteotomy rule 2, where your cora is at one point, your osteotomy is a little bit away. But your cora and actual axial correction angle remain, axis remain at the same point like cora. So in a recurvatum, you just turn the banana the other way around. So this is anterior, that is posterior. So don't get fixed to AP lateral. In a deformity surgeons, so you have to do based on the patient. Don't worry about AP lateral. That's for general description and for common people. Whereas the deformity people should have a 3-dimensional outlook. That is how it is being corrected. Now, similar case here, you can see a sagittal recurvatum deformity. That is the knee joint line. This is the proximal axis, distal axis. That is the magnitude. And I cannot do an osteotomy here. This is a tibial tuberosity. And this tibial tuberosity length is okay. So I don't want to do an osteotomy there and lengthen it. So I decided to do an osteotomy at this level, which is far away from the cora. So this is osteotomy rule 2. So that is a real deformity. So this is the recurvatum, which is well compensated by flexion at the knee joint. So the knee joint is kept in flexion. So it looks too parallel, translated. By why it is translated? Because there is a recurvatum deformity, there is a flexion contracture. So two deformities, flexion contract, two angulation produce one translation. So if I want to correct it, I have to correct this, and the flexion deformity being the knee joint mobile will get automatically get corrected. So this is the real deformity. Knee joint is fully flexed, and this is the real recurvatum deformity. Now I have to bring this back to this place. So that was the X-ray, proximal tibial recurvatum deformity. So I did osteotomy rule 2, a double level lengthening. She need lengthening more. So I did one more lengthening osteotomy at that level. So here it is little bit of lengthening. So you can see that is the proximal lengthening, distal lengthening. And you can see the bump there. It happened because of the osteotomy rule 2. But overall, it looks straight and the bump will disappear in due course. So that is our limb before and after. You can see the step here, that step has disappeared. Now I go on to the contractures of the knee joint. So this girl had a popliteal pterygium syndrome. Popliteal pterygium syndrome is a very rare condition where there is a web-like structure connecting the around in the popliteal area because of an abnormal muscle from the ischial tuberosity. Crossing the bypassing the knee joint, it goes inserts onto the tendo Achilles, go up to the heel. So they develop equinus as well as the contracture. In such cases, their sciatic nerve will usually go and lie around at this area. So I did few cases where I released it and I found the sciatic nerve is the right limited structure which I cannot stretch anymore. So even after release, I used to get only 5 to 10 degrees of correction, which is of no use. So now I stopped doing opening that area. I put a frame like this with the knee hinges. It gives a half ring there, which can give in full flexion. I can add further half ring later on. So in this particular case, I did a peroneal nerve release. You can see the, not peroneal nerve, it's a sciatic nerve. I removed his fibrous band, and that is a sciatic nerve just under the skin. So here, I have to lengthen her sciatic nerve. It is not knee stretching, whereas it's a sciatic nerve lengthening. So whenever I plan for that, my distraction should be, the hinge should be there, but my distraction should plan for sciatic nerve. If I plan for the knee joint, then her sciatic nerve will die because of over distraction. So I have to lengthen the sciatic nerve. So that is my structure and design to correct it based on the rule of similar triangles. I must do a sciatic nerve lengthening for 1 to 1.5 millimeters a day. So that is how the frame was there. This is the distraction rod. It's slowly getting corrected. And I got the hyper correction without any peroneal nerve palsy. That is how it was fully corrected. She can do an active extension. She got about nearly 60-70 degrees of knee flexion afterwards. Now, when you have a oblique plane deformity, you keep the banana in an oblique plane. Whichever position you want, you can just keep it. So in the AP view, you can see this deformity. In the lateral view, you can see that deformity. In reality, this is the same banana lying in a different orientation. So it is the same deformity, the hinge in a different levels. So that is why you must use a banana so that you don't get fixed to any of these things. So this is an oblique plane deformity. You do an osteotomy and correct it. That is how the correction at the end. See, this is an oblique plane deformity banana of a young boy. You can see that AP view, there is a deformity, valgus. In the lateral, you can see a recurvatum deformity. That is the AP view and lateral view. So you can combine these two things together and made an oblique plane. This is the hinge. That is the distraction rod. Here you distract it. This is the hinge there, and on the posterior side, you open it out. So this both AP lateral plane can be corrected simultaneously by the oblique plane deformities. That gets opened out. You can do an osteotomy there. That is osteotomy. So now you can see it is the regenerate is growing and fully corrected on the frame. And this is after correction. Now look at this patient, little more complicated. What is this deformity? See, this was the X-ray which I got. Now I planned it in such a way that this is the proximal axis and the fibula. Ultimately, so here I planned on the tibia. When I came distally, because his tibia is unpredictable and small and short and not much of a size. So I started planning from the tibia there and planned it onto the fibula. So this is the magnitude deformity I have to correct for this lady. And after correction, I thought I will get the correction like this and translate her ankle laterally to bring the distal fibula into the center of the knee joint, center of the distal fragment. So ultimately, the end of the correction should be like this. So it starts from the tibia and goes on to the fibula, do an osteotomy there and correct it. So that is what I did for this way. I spanned the knee joint, put a fixator there, and you can see it is getting corrected. And that much is lengthening has been done. At the end of it, correction. The knee joint has been, the ankle has been translated so that it comes under the fibula. So this is a knee contracture plus virus and recurvatum deformity. This was our X-ray looking like, and that is the frame. And double level correction on the tibia. I got lengthened the tibia like this. From there to here. So the final result, from here, she could walk like this. I went in for a little bit of extra valgus. Now, sometimes you can combine this rotational angulation along with the other angulation, like oblique plane or whatever thing. You can join together. For example, here, a 90-degree valgus and 180-degree rotations. You can do an osteotomy and make it rotate around this axis, and the whole thing can be brought back to normal. You can see here, see that the posterior part rotates and gets corrected. It's an oblique osteotomy. You can see that this is the posterior side, that is anti. It rotates and comes back. Because oblique osteotomy, it comes with an oblique plane. So I had a patient who had a 30-degree valgus and about 30-degree external rotating deformity. So I corrected like this. I made the ankle, calculated it. Rotation was also planned and made appropriate axis on the bananas. A lot of hard work on the bananas and made the osteotomy like this with a hinge. And I thought I'll correct it like this. You can see that rotation also got here. You can see the horizontal toothpick and little oblique toothpick. And at the end of it, you can see this is in two different planes. After correction, you can see the toothpicks are aligned. And that is the osteotomy. And corrected acutely without taking any wedges. I not removed any wedges. So I could correct 30-degree virus and 30-degree external rotation without removing any wedge in an oblique plane angle and corrected it and then locking planes. So if I can do it on this banana, I can do it on the patient. So this young girl who had this deformity, severe valgus deformity, I corrected in young age. Then I lost her follow-up. So she started relapsing. Then I put an epiphyseal appear by the staples at that time, and I could stop it there. She came to me when she became final year MBBS. So at that time, she had 36-degree valgus and 30-degree external rotating deformity. So all these things, and she had a very limited knee movements of about 30 degrees, which I don't want to spoil it. So I don't want to do, I just remove the staples, plan to remove the staples and do the 30 degrees of valgus correction and 30-degree external rotation, and limb length disparity about nearly, overall it was about 12 centimeters. But after correction, I want to save some bone. So if I remove the bone in there, then my shortening will be more. So I thought I have to save maximum length. So this is what I did. 36-degree valgus, 30-degree external rotation, 12 centimeters limb length disparity, and only 30 degrees of near range of movements. So this is my plan. If I do it acutely with the fixators, definitely her knee movement will come down. And I want to avoid a frame on her femur to correct valgus and external rotation without bone loss, and an oblique osteotomy was planned, and to fix with an LCP and correct limb length disparity at the tibia. So this is what I done. I did an osteotomy there and corrected with, I didn't lose any bone length there. So my shortening has been reduced. This is the final correction. At the end of it, you can see her femur up to there, tibia over lengthened by about 7 to 8 centimeters. That is how at the end of it, femur plate and the tibial deformity correction, tibial lengthening. The osteotomy has completely healed and the regenerate is completely matured. And this was how she was walking. So since I have the 30-degree movements, she can walk practically normal. She has now completed her medicine and looking for some PG or something. So look at this young man who had a oblique plane deformity. You can see a valgus here and the recurvatum. And there was a rotational deformity. You can see here, the fibula is at the posterior, the fibula is at the anterior. So posterior fibula, anterior fibula is the lateral view. That shows there's a rotation deformity. So there is stiff non-union, valgus 14 degrees, recurvatum 26 degrees, internal rotation deformity of 40 degrees, equinus ankle, and old Lisfranc dislocations. And the valgus and recurvatum resort to one oblique plane deformity. And this oblique plane deformity and internal rotation resolved to a new oblique plane deformity. So this is how my frame was looking like. You can see one hinge at that level, the other hinge at this level. You can see one hinge here, the other hinge here. The hinges are on either ends, and that is the distraction rod. So it corrects rotation, everything in one go. So you can see that this is a distraction rod, the hinge here and hinge down there, and the distraction rod. It automatically corrects the external rotation, and the pre-assembly fixed to correct all deformities in one go. So this is the end of it. It is completely correct. You can see the regenerate, new bone formation, and final correction. So nowadays we have earlier I have been using Hexapod, then SUV, now Defix has come to the market. When you have a knee subluxation, the translation deformities, and neglected dislocations, if you want to bring it back into the right position, most of the time, we have been doing it earlier with the conventional Elizero, but now we have a software for that. I put a fixator there, and this is old Hexapod. I've done with SUV, and nowadays Defix, all this goes by the same type of procedure by 6-axis corrections and software-based deformity planning. So you, whatever this thing you put into the software, values and all, you put it there, and it will dictate the correction. Ultimately, you can get the final reduction before and after. But the problem here is, when you start doing these cases, you start getting more and more complicated cases to correct it. So the headache never stops. So only thing, you stick on to the correct deformity by proper understanding, correct at the correct Cora based on correct planning by correct method so as to get the correct correction. So get it well. Thank you.
Thank you, sir. Thanks a lot, sir, for a legendary talk, sir. So before we move to the discussion, I will really welcome Novikov, sir, in the panel, sir.
Okay.
Sir, please unmute, sir. Yeah.
Good afternoon, dear colleagues.
Okay. How are you?
Thank you. Everything is good.
Yeah. Looking more smart.
Thank you.
Yeah.
Sir has just recovered from Omicron right now. He is in quarantine.
You too. And can I a little bit say, Dr. Vasudevan, thank you very much for your magic, excellent presentation, because just now you show us not only unbelievable results, you show us knowledge, alphabet of correction, because without that, we cannot properly support of patient with severe deformity. Thank you.
Thank you, sir. Any question from the panel, sir?
Vasu sir,
Yeah.
up to what angle you prefer acute corrections in valgus or varus correction, especially valgus?
In the metaphyseal area, I usually stick on to around 20 degrees.
Up to 20 degree, you prefer to
Yeah.
use the implant,
Yeah.
acute correction in implant.
In diphysial area, how much you do the correction?
Pardon?
In diphysial area,
In diaphyseal area, if I can get it, I can go a little more by plating and nailing, because the implant will be retaining there more.
no. In Ilijarab, how much correction of the degree of the correction one can do that?
In Ilizora, anyway, you are doing only slowly, no? Any amount is okay.
Definitely.
Yeah.
Sir, any more questions, sir? Rajat, sir? Mangal, sir?
May I ask a question?
Yeah, please go ahead, sir.
Vasudevan, with so many deformities of such acute angles, didn't you think of excising part of the bone as a wedge and then correcting acutely, correcting the further, which becomes more easy to treat, and then lengthen the remaining part? You got
That's
my
an
point.
option.
That is what I try to do when the deformities are very severe, like what you have shown. Of course, I don't have the cases that you have, but I do have other varieties of cases which I have done like that. I shorten by taking a wedge so that part of the deformity is corrected on the table, and then gently correct the deformity and then lengthen it also by placing the hinges. You know how to do that. I think that works out a little bit easier for me. With little bit of experience, I have started doing that kind of thing instead of leaving it and thinking that the wedge is going to make more shortening and all that.
No, when you want to lengthen it there later on, what is the extra advantage on that? When
Extra
you're
time is
planning to
required,
lengthen the
agree.
same focus,
I'm not saying no, but
when you plan to do the same focus lengthening, it is better not to disturb that area.
Sir, I want to know that when you are removing the wedge, do you do some open surgery?
me, hello,
Hello?
all close, not able to hear anything. Yes.
Ashok sir, please go ahead.
Yes. Arshad, I want to know when you are going to remove the wedge, do you do the open surgery?
Yes. We do an open surgery, a small open surgery. It's a little bit bigger than the corticotomy side, depending on how much of wedge. We are not going to take a big wedge of 45, 60 degrees and all that. just a maximum of 30 degrees so that it reduces the deformity. And then you keep it for 15 days and then only start distracting. I don't do it within 5-6 days immediately because we have opened it from one side. But I think that reduces the tension of correcting deformity too much and then displacements occurring and more angulations occurring at the fracture side. I mean, our deformity correction side. That is one thing I have found to be a little bit helpful for me. Doing a wedge, reducing the deformity, and then continuing doing deformity correction. And then
to me, I think
because
if
we are
you're
doing
taking
it
a wedge
slowly, so it
out,
doesn't matter.
so in me, I think when you're taking a wedge out, take the appropriate wedge and fix it with the plate. Why do you Elizaro?
No, the deformity is much more. So you can't. So you are helping correcting the deformity little bit by removing a wedge and then continuing with distraction on the inner side.
Here, no, I've corrected 140, 170 degrees.
Have you? No, 100% correction. You don't require Elizaro. You can put a nail plate or Elizaro, whatever you want. If you can get 100% acute correction, and then you do lengthening if you want to do it. Dr. Noviko, good evening, sir.
Oh, good afternoon.
Did you
Good
get
evening,
what
good
we were
evening.
saying?
The extreme,
Hello?
sir, in extreme shortening cases of ability cases, when you do lengthening, you do in multiple stages or what, sir? Deformities, sir. Vasu, sir.
Loud, please.
Can you hear me, sir?
Yeah, come
So
on.
severe deformity in ability cases, like in 6 or 7 years, and you have too much of shortening is there, like 4 or 5 inches or even more. You do the lengthening in one stage or gradually, just to avoid neuropraxis.
Yeah. You can always do lengthening little later. I do the primary deformity correction and take care of the nearby joint as much as tolerable. Don't develop any other equivalent deformity or knee stiffness with a limit. Only correct. The primary thing is the deformity correction. So if you can lengthen, you can always do little later. But whereas in a little more older child, like which I have, the one I showed now 170 degrees, I did acute correction, I mean, single stage correction, but I told her she may not have knee movements. She got some 20-30 degree knee movements, but she wanted full correction because she cannot afford anything later on. One goal, it has to be finished. So they were ready to accept the knee stiffness. So if they are ready to accept knee stiffness, then I will correct it.
One more question, sir. Like in severe deformity, do you also calculate with the multiple formula, the soft tissue calculations? Do you also do, or just the bone correction? Do you calculate before that, sir?
Yeah, I have to find out both soft tissue and the bony.
Yes, sir.
And the rule of triangles and slowly correct it. If I want to reduce it, I do multiple level osteotomy.
Right, sir.
And fix it so that the magnitude comes at 2 levels. I shown that 170 degrees. So I did 105 degrees distally, 65 degrees on top. So 2 levels.
Right.
So my headache is less. The nerve stretch or the soft tissues are stretching at 2 different levels. If I start correcting everything at 1 level, then I may land up in more trouble. So I do a lot of time on bone ninja procedure and do my workshop on that. Maybe in such complicated case, I do about 10-15 times. And I criticize myself. And finally come to a decision. And such patient, I ask them to come at least 3 times for review. Each time I reevaluate, recalculate, and finally come to a decision after 3rd time. If they are not coming 2nd time, I'm happy. If they are interested, they will always come back. No.
Right, sir. Right, sir. Thank you, sir. Any more questions? Mangal sir is there?
One more
I'm
question.
there.
Vasudevan?
I'm there, but it's all clear. No questions.
No more questions.
Prasad sir has a question.
Dr. Vasu,
Yeah.
you have shown that rotational correction with without SUV.
Yeah.
There is a possibility if the rings are not, if the bone is eccentric, then there will be some translation occurs because of that.
Yeah.
How you do that?
The
See,
old time primary, that is a conventional Elizaro, the deformity correction, the principle is, we call it as alert. Because the ring's center point of the ring may not match with the intramedullary axis of the bone.
Yeah.
When you do these things. So that is a possibility which has been known many years. No? We know it already. So what we do is we do an angulation correction first. That is called alert A. Then lengthening. Then I do rotations. And translation correction is corrected at the end separately. So translation is the last step.
Yeah.
So all these procedures can end up with an unacceptable translations. Then you correct the translation at the last point.
Yeah.
So go
That
by
is just I want to insist.
Yeah. That is the old alert of deformity correction.
Yeah.
Because it's easy for us. Because we have been doing from 1990s. We have gone through all the developments. But now the people who do the SUVs and all directly, they may not have that way how to do these things.
Yes.
Actually, what I feel that, for example, when we were correcting the varus deformity, there was a rotation also. So when it reached to the valgus deformity, valgus, achieved the valgus there, so I found that none of the cases of the genu varus of valgus, when it is a valgus, then we found when we were correcting the polio also, the varus rotation, internal rotation always corrected. Because you have never seen a case who is having valgus deformity with the internal rotation, usually. So when we are correcting from the varus to valgus deformity, most probably we have find out in our Ilira frame, lot of rotation is corrected.
Yes, sir. So if you have more questions, or shall we move for Nico sir's case? Any more questions, please? No. So shall we move for Nico sir's case presentation?
We can move with that case. Later on, we can take questions if there are so many.
Right. So before Naviko sir starts his presentation, I request. So we have next our eminent international faculty, Professor Konstantin Novikov sir, the Chief of Elizabeth Department of Kulkarni. So he'll be presenting his case of knee deformity, knee virus for discussions. Before that, I would request Agarwal sir for a brief introduction of Novikov sir.
Yeah, Professor Nomiko is the chief of in one of the department lengthening in the Kulkarni Institute. He's working from a very long time and is an expert in lengthening and other deformities. He's very soft. And the best thing is he can speak the English. That is a great problem in Kulkarni. He's a very nice man. He has visited our Gorakhpur also. He has also visited to Goa also, and very, very competent person with his surgery. He's a master of surgery. We can say that he's a master of his surgery. That's all.
Thank you, sir. Thanks a lot, sir. Naviko sir, please share your screen, sir.
You can see?
Yeah.
Not yet, sir.
Not yet?
No, sir. Please share.
Just a moment. Now?
Yes, sir.
Yeah.
Please make it full screen, sir. Slideshow mode.
And I want to say for chairman, for all of colleagues, thank you very much for your invitation and possibilities to stay with you. And just now I am more than happy because with your activities, with your experience, Elizarov methods step by step back to the Russia. Now I stay in full, how I can say, I stay alone because I need to follow instruction of epidemiologist. I have SARS, and 2 weeks ago, when I have planned go out of Russia, in airport I have positive PCI, and still I haven't any contact with anybody, only with you by internet. And Dr. Shamsul Hoda give me chance show small experience with some I think interesting case when in Russia doctor orthopedist surgeon start support patient with how we can say golden standard with 8 plate, and then haven't any result, continued correction of deformity with plaster cast, with orthopedic brace, but finished our treatment only with Elizarov. And this is a small presentation from mobile, which sent me patient before treatment. I invite you to our winter. And a few years ago, I meet with all of these great surgeons when was Ruta ASAMICON.
Dr. Novikov, your slides are not moving.
Not move?
Please,
Yeah.
please, no, sir. And please make it full screen, sir. Please make it full screen.
I am just now on the full screen. This
You
is
can just
full
share and do
screen.
it again. Yeah, it's moving, sir.
Now slides are moving, but the screen is
It is not full screen. It is not full screen. Please
I try
click
my
on
best,
slide.
but I
again,
don't
sir.
know what I need to do. Just a moment.
The full screen button, sir. So on the bottom, sir. The slideshow mode, sir.
What's happened? I don't know.
On the bottom right, sir.
Very sorry.
On the bottom right, sir. Bottom right.
Bottom right, sir. The slideshow mode, sir.
Just adjacent to the magnification marker, na?
And nobody who can support me here. Very sorry.
Okay.
Just a moment, I try.
So on the lower side, on the lower right, starting from the right side, the first
Yes,
marker.
sir, yes, sir.
Yeah,
Yes, sir,
this
yes,
one.
sir. Exactly, sir. Click on that, sir.
And now,
Uh,
Not yet. Not yet.
That is slow.
Not
Okay,
yet.
we can go ahead with this if the
Please
slides are
move, sir.
moving. Actually.
No issue, sir. Please move to the next slide, sir.
and just now you can see or no?
Yes.
Not full screen, sir. No full
But
screen.
I have full screen. I don't know.
Go ahead, sir. Go ahead. Go ahead.
Yeah, please go ahead, sir. Maybe internet issue, sir.
Share it and unshare and reshare once, please.
That will solve. May solve. That may solve.
Please unshare and then share the PowerPoint again.
Yes, sir. Please share again, sir.
This moment.
Yes, sir.
Now it's right. But you're on clinical case 2, if that's the one you want to show.
This is clinical case, yeah, too. But just now I cannot change. Very sorry, colleagues.
Just on your, yeah, it's moving, sir. Please.
And this is history start very easy. Baby fall down and has fracture, closed fracture. Doctor start support with closed reduction, unsatisfactory. Next day support with K wires, with good, achieved excellent result, put plaster cast. And I don't know how in India, but in our center, we never pass any wire through grow line. In the Russia, doctor very often put because on the finally get good result. And after 1 month, doctor satisfied with this picture. Everything is good, but we need think 1 month ago, K-wires go through the grow line. Elizarov methods give us possibilities pass wire above and below grow line. Little bit loss function of knee joint, then slowly coming varus deformity. Baby grow and varus start grow. On this picture, everything is good. In other picture, we have varus deformity. Gold standard in the Russia use 8 plate. Never use Elizarov frame for correction, any correction, varus or valgus. Usually for child, our colleagues in Moscow and St. Petersburg and in other big city use only 8 plate. Very easy, very quickly, few days in hospital, and then discharge. And my colleagues in the Russia called this is controlled osteosynthesis. I not understand how we can control it, because this is situation out of hand orthopedic surgeon. And from beginning, this is goal, start use orthopedic brace for full day, for many months. But what you think? Why with 8 plate this area doctor won't fix, but deformity increase, varus deformity increase? And for me, when doctor use 8 plate, doctor still natural potential for growth, because on the end with this patient, varus deformity, yes, this is problem, but with time, problem invite problem. So many months, more than 3 years, many times, baby change orthopedic brace for correction, but varus deformity increase. Remove 8 plate, and you see, before we have only varus deformity, with time she has more than 6 centimeters shortening. And my opinions, this is not only first surgery, this is 8 plate too, still some centimeters from this baby. Right and left, absolutely different condition of grow line. 3 years spent, I think, for nothing. Remove, and then more than 3 years, doctor not ready for support with Elizarov. This is situation in the Russia. And how we can support without Elizarov frame in this baby case. And when she come in our center to Kurgan, she has limb length discrepancy near 7 centimeters. almost 100 millimeters deviation, and very, very quickly tired. We put simple Elizarov device, use only Kirchner wires, lengthening, simultaneous correction, very quickly discharge her to home. We have only one problem with some inflammation, remove this wire, and forgot because we pass all time extra wire, and this give us chance not go second time for in operation theater. We have enough amount of Kirchner wire. After discharge, she all time walk outside of his house. Here you can see she with Elizarov frame. When coming time, very quickly remove frame, and only one problem, small contracture of knee joint. And yesterday I show this presentation on Bangladesh, and we cannot get result with only with surgery, because our results, this is result of so many person, including nurse, physiotherapist, and for her support back to the normal life with her function. This is man. 10 days ago, together with me, I have positive SARS, I have COVID. 10 days ago, this man first time get positive SARS. 3 days ago, he is died. COVID is COVID. But life is continued, and this man give her excellent result with knee joint. And thank you, colleagues, for you. Today I saw perfect, excellent knowledge how we can, with Elizarov philosophy, with Elizarov possibilities, we can get magic results with any deformity. And Dr. Vasudevan, I'm agree with you. For me, better step by step, correct one deformity, another deformity, another deformity. I think not so good when we eat soup, meat, drink tea, eat apple, because any food need time. Any problems need time, and our activities. When we in one moment want correct all of deformity, I lost more time, and my result not so good. Maybe I am not ready, for example, for SUV or for technique when we try correct all component when patient has multi-component of deformity. I correct various deformity, then precurvatum, then torsion or translation, like that. And I want to repeat again, thank you for your knowledge and for your experience, because just now so many young doctors, I think, will follow you. Very sorry, not only in the India. And I invite all of you for Elizarov readings on this year. I hope when COVID will finished, we can sit not like now in front of computer. We can meet face to face. Thank you very much, colleagues. Very sorry.
Thank you, sir. Thanks a lot, sir. Request question from the panel, sir.
Dr. Novico, I want to know why the figure 8 plate not work. What is the reason? Same thing I found in one of my case that I applied the figure 8, the deformity was not corrected. In so many other cases, it has worked. In some cases, it worked. What do you think? What is the reason behind this?
And Dr. Agarwal, I don't know reason why so many doctors just now correct. For example, rickets, varus deformity. Gold standard in the Russia, only 8 plate. And all of these doctors against of Elizarov methods because they think, not only think, the Elizarov method is very aggressive for child because big construction of his body. And I think our methods, all of you are worker. I cannot say we are slaves or Elizarov methods, but Elizarov methods need time. Dr. Rashad, do you remember? This is not for all of Dr. Elizarov methods. This is methods for crazy doctor who already spend time, spend life. Because 8 plate and next, 8 plate and next. Yes, situation out of hand of doctor, but patient don't need any control and contact from doctor. With Elizarov, you need not each day, but very often touch our metal. And in my practice, I use 8 plate because my chief strictly recommend correct. I haven't good result with 8 plate, including this baby. She come from St. Petersburg, from more than 3 years treatment with 8 plate. And what you think? Why? Doctor with 8 plate fix lateral grow line. Why? Varus deformity coming. My opinions, this is K-wire. K-wire, not only fracture, including K-wire, damage some grow line of this baby. And what we need to do for prevent this deformity in the future with another patient. What do you think, Dr. Agarwal?
Yeah. Because the deformity, I personally feel when we put the K-wire, it damages the epiphyseal growth there.
Yeah.
So that is the most thing. In some of the cases, I found that later on, because we have damaged the epiphyseal plate, so that is responsible for the growth deformity. That is most important. So we should avoid using the K-wire plate. So, and those cases, when they have the malleable and other things, we will apply the Elizarov frame, not the K-wire.
Sir, can I?
Yeah.
Sir, in these cases also, if the child is of less age, then we can also go with the 8 plate, but we need to consider that in post-traumatic cases, there are fascial bar formations because of the trauma of the K-wires or like because of the trauma itself. So we need to exclude those bars. So it's better to get the CT scan done just to exclude the bars. If there are bars and child has some growth remaining, 3 or 4 years of growth remaining, minimum 2 years of growth remaining, then we can go with the bar excision and then we put the plate. That's also an option. It's not about that absolute no to 8 plates in this age group. And along the adolescent age group, 11 to 12 years, especially in females. So we don't think that there is a premature fusion of the fascial plate. We directly plate the 8 plates. Put the 8 plates.
Colleagues, my question is, why this baby doctor put 8 plate for correct varus deformity?
So what was the age of that patient?
Start from 9. 9 years old.
He has placed the plate at the age of 9. So
Yeah.
If he was placing the plate at the age of 9, then he must have excluded the fascial bars because it was a post-traumatic deformity. So there must be fascial bar formations that have not allowed the deformity to correct because of 8 plates. Otherwise, it's I don't think so. Why it has not been corrected, I don't know. But senior faculty can comment, Mangal sir, Vasu sir, or because we must have to exclude the fascial bars, especially in post-traumatic cases.
And India, from beginning, colleagues, from beginning, she has fracture. How you can support this girl? Displacement, you will fix this fracture with K-wire through how?
No, in this age group, sir, in 8 years, 9 years, we use K-wires in lower age groups, but we can also use it was the type 2 fracture. We can use the screw in the upper fragment, and we can avoid that crossing the fascial bars, physis. We can avoid the crossing physis. Vasu sir.
Yeah, whenever you do
your recommendation for next patient, how we can start treatment?
Sir, if
patient like this,
if the patient is of 9 years, 8 years, and if she is a girl, it's okay with me that 8 or 9 years, girl or boy, it's okay with me. If there are 1 or 2 years of age is remaining, then definitely in a post-traumatic case, I would go for CT scan just to exclude any fascial bars. And if the fascial bars, after the bar mapping, the bar is not that much that I can just take it out, then I will go with the, after fascial bar excision, I will go with the plate. Otherwise, if the bar is much more, then definitely I will go for Ilizarov.
And you see, 3 years in St. Petersburg, doctor try correct varus deformity with orthopedic brace. What do you think?
Orthopedic braces are not recommended nowadays, sir. In this age group, orthopedic braces are not recommended. And sir, Vasu sir and Mangal sir can further comment on this.
Yeah, the indication for any 8 plate is the most important indication is there must be growth on the opposite side for at least 2 years.
For at least 2 years, yeah.
So otherwise, it's not going to work. So in this case, with a trauma, post-traumatic one, and you don't know how much time they must have attempted in reduction.
Yeah.
And that growth plate must have been damaged.
Definitely.
And I think it's a global growth damage on medial side. And the lateral side, because it's having a metaphyseal spur, it's a type 2 epiphysis, the lateral growth plate was still growing.
Yeah.
And I think the 8 plate helped to reduce the deformity. But since the medial side is stopped growing, lateral side is also stopped growing because of the plate, it has gone for extensive shortening. It has done its job.
You see, how many, more than 5 years doctor wait, because doctor not ready use Ilizarov methods in the Russia. And just now, you see, this is for you, for all of us, this is simple case, simple deformity, small shortening, but we lost more than 5 years because, and just today you show very difficult.
It was
extremely difficult cases, and with Ilizarov you not lost time. Here, baby grow, and 5 years, I think doctor is lost. I don't know how we can support with this patient and in the Russia. And just now I am happy because sunrise on the east, and Indian doctor, Bangladesh, and another country in your area show Ilizarov philosophy. This is doesn't matter from which material we will use, because now in internet I find so many Ilizarov frame, but this is not Ilizarov methods. And our device possible make from bamboo or another wood, but this is real Ilizarov methods if we will follow rule. And for me, Ilizarov philosophy give possibilities in our hand for support this patient. Thank you for your meeting. Just now night in India, and you stayed and change your experience. I'm happy, very happy. Thank you.
Thank you, Dr.
Спасибо
Navi.
большое. Приезжайте в Россию.
Thank you.
Thank you, sir.
Thank you. Thanks a lot,
Thank you,
sir.
sir.
Thanks a lot, sir.
Dr. Shamsul, you can conclude it now.
Yeah, before concluding, we just we'll be having our next meeting on Sunday, 13th evening, 8 p.m. sir, and we might have guest faculty, Dr. Fadal from Cairo, and we have Manish sir for a case. So it will be, I'll just tell you, Dr. Manish sir will be talking on digital tibia fractures, including pelvic fractures, and Mohammed Fadal sir will be talking on orthoplastic fibula electro-assisted technique, that is orthoplastic fiat. So request everybody to be there for next Sunday, 8 p.m. And Novikov sir, if you are free, please be as a guest panel on that day also, sir. I'll send you details, sir.
I will call you because just
Sure,
now
sir.
I stayed in Moscow. I'm in isolation.
I know, sir.
When doctor give me freedom and I will back to home, I will contact with you. Just now,
Okay,
this
sir.
is my prison.
Right. Thank you, sir. So I
Enjoy,
request also
enjoy.
Dr. Ravi Chauhan for
Enjoy the prisoner life.
Thanks.
Yeah.
Yeah.
Thanks, Vasu sir. Thanks, Ashok sir. Thanks, Dr. Novikov. Thank you, Agarwal sir. Thanks,
Thank you.
Mohammed sir.
Thank you, colleagues. Thank you.
Thanks, all of you.
Thanks a lot, sir. Thanks and good night to all. Stay safe.
Good night.